Hello, I'm Dr. John Kruse, and welcome to the weekly question and answer session regarding ADHD, mental health, or other things in general. I will recap the videos that were released this past week. There's 3 of them, so that will be about a minute each. And a reminder that the information here is meant to be information. It's not meant to be medical prescribing or specific recommendations, since I have not evaluated any of you. And also a reminder that I do have a subreddit under Dr. John Kruse, DrJohnKruse, if that's a better venue for any of you for sending in questions. So the 3 videos that were released this past week, 2 of them are re-recordings, fixing the sound. One was on getting back on track if you have ADHD. And I suggest the ARM approach, ARM. A is for awareness, R is for reminding what you're trying to do, and M is motivating. So you have to be aware that you're off track before you can do anything about it. You have to be reminded about aware of what you were trying to do at that time rather than what you got off track on. And then you have to be motivated in terms of getting back into that task. With motivation, I urge people to get in touch with their wants rather than their needs, because some part of you really wanted to do this. And I can, again, go into more details on this in the question and answer, but that's the back on track approach. The calendar schedule is your best friend in this endeavor. The second video that was resounded this week was on orexin receptor blockers, the DORA drugs. So those are Belsomra, Dayvigo, and Quviviq. And these are sleep medications that work unlike any other medications out there. So most of the other medications for sleep just sedate you further or increase the sedation, the sleep element or sleep system in the brain. The DORA agents actually are blocking the arousal system, and it's a reciprocal system. So usually when sleep is on, daytime arousal is off. When arousal is up, sleep is down. So this is shutting off daytime arousal, which studies indicate most of people's problems with insomnia is not a defective sleep system. It's a problem with shutting off daytime arousal. And the downside of these medications, if you're used to relying on a medication to knock you out or sedate you, these are not particularly sedating. The good news, again, is it may be helping with more normal restorative sleep, and we can get into issues or complications there. And then the third video that I re-released, actually I updated it, was on psilocybin and mental health. So there are now in the US more than 134 studies have been registered with the FDA. Only 2 of them have come to phase 3, which would be the stage you need before approval as a medication. The FDA has not approved it, specific drug for a specific incidence. They have allowed it for emergency hastened exploration status for depression and initially for treatment-resistant depression, now depression overall. The studies that have come out so far are quite impressive. They look like they have robust effect sizes for psilocybin for depression, for anxiety, for PTSD, for substance use disorder. The big problem is that the sample sizes are still small for depression, which I think has more studies than anything else. It's still fewer than 2,000 people in all 6 studies total. And these selected individuals were highly carefully selected. So they usually couldn't have a host of other coexisting conditions. Many of them had previous experience with psychedelics. And the treatment conditions also entailed fairly extensive either monitoring or guidance. Some have argued that it's not really therapy in some of these, but probably much more intensive controlled environment and supportive environment than many people will get when these are, if they do indeed become widely available. And one major problem with the psilocybin and other hallucinogen research is it's really hard to do any meaningful randomly controlled blinded studies because almost all the time subjects can tell whether they're getting the hallucinating substance or not. Whether hallucinations are even a necessary part of the experience, there's a variety of opinions and I would say still inconclusive data. So those are the 3 videos. And again, you're welcome to ask questions about other ADHD topics, other mental health topics. And I see there's a few questions here already. So good morning, Dennis, or good evening for you. So Dennis asks, why isn't mescaline widely studied in mental health? So that's a good question. And I don't have the answer to it. I'd say some of what, so a little history in the US in the 60s, psilocybin, actually the synthetic form psilocin, was made by Sandoz, one of the biggest European worldwide pharmaceutical companies in the world. And it wasn't until Richard Nixon, the war on drugs in the very early 1970, put a ban on any use of these hallucinatory substances, moved them all into Schedule 1, which means they are classified as potentially dangerous and with no medical value. And that shut down in the US virtually all research from 1970 until late in the Clinton years. So it makes me feel old, but it was almost 20 plus years before any research could be done at all. When research started, it was largely funded by a very small number of individuals who were quite interested in making this eventually more widely acceptable, but they chose the substances that they were most interested in. So there's a very idiosyncratic history in terms of what they deemed was worth investigating. I don't know why mescaline hasn't been near the top or among those highly investigated since then. I don't know whether it really doesn't seem to have as large a therapeutic role or whether it's just cultural or other factors going beyond. So that's my answer. So what I would say is most of what we call classic hallucinogens work on the serotonin 2A receptor. There's a few that work differently. So ketamine does seem to work different systems. So that's where I'll go there unless someone has a follow-up question. So hi, Max. Why are DORA medications? So the DORA is the DORA, dual orexin antagonists. So they're blocking the orexin section. Why are they referred to as hypnotic drugs? And what is the difference between hypnotic and sedative? So hypnotic, and I think it's Greek for sleep, but somnos is also sleep, somnolent and hypnotic. So a hypnotic drug is one that puts you to sleep like in a hypnotic trance. A sedative is one that dampens you down or sedates you. Neither of those drugs, and we've talked about the term stimulant often, none of these have precise biochemical definitions, or if they do, the precise ones are not what's widely used in practice, both among psychology, neuroscience, and other biological researchers in the general public. But again, so again, the classic, almost all of our other sleep medications, hypnotic agents, are sedatives. So in the 60s and 70s, it was the barbiturates, which are hardly ever used now because they are quite lethal in an overdose, suppressing the respiratory centers. Then in the early 90s, so after those were deemed too dangerous, the benzodiazepines were promoted as, these are really safe, because it is very, very hard to overdose on Valium alone or Klonopin. You can take so much you'll fall asleep, but even a month's worth is extremely unlikely to kill anyone in isolation. So if you combine them with even moderate amounts of alcohol, they can become quite lethal, but it's more that they're amplifying alcohol's effects on respiratory systems. So essentially when you die from oversedation, it's usually sedating or knocking out or suppressing the breathing centers, and you stop breathing and die. So it's at the central level, not the lung level of dying. So the benzodiazepines, again, in the 80s, I guess this would be, were touted as so much safer. And then it became clear the longer they were on the market, one, lots of people became tolerant to them, two, substantial numbers of people to become addicted to the benzodiazepines. Three, with most of our sleep agents, the longer you use them, the less effective they are measurably. And so then a new class of drugs, so the benzodiazepines work on two different benzodiazepine receptors. One is for short, this is oversimplifying, a sleep benzodiazepine receptor, and the other is a anxiety benzodiazepine receptor. But benzodiazepines also have effects on muscle tension and on memory. And so the benzodiazepine receptor is on the GABA system, and alcohol also binds to this GABA system. So taking too much of the benzos is like a little bit like being drunk, or a lot like being drunk. So the Z drugs, which are zolpidem, zopiclone, and I'm blanking on one, Ambien, Lunesta, Sonata, were developed as what are called officially non-benzodiazepine receptor acting agents. So structurally, they are not the same. They don't have a benzene ring with two azole moieties stuck to it. So they are not benzodiazepines, but they are binding to one of the benzodiazepine receptors. If you take massive enough doses, they're binding to both benzodiazepine receptors. I sometimes tell the story of someone I treated 25 plus years ago, where his previous psychiatrist had used Sonata, which is a short-acting Z drug, only FDA approved for sleep, but using it at massive doses. They were taking 10 pills every 2 hours for anxiety. Clearly, they developed massive tolerance to it. But so again, the specificity depends on the dosage. If you go massively high, the Z drugs have greater or less specificity. So again, all those drugs are sedating. And again, most of the people who have insomnia, and the estimates are more than 90%, do not have a problem with sedation or the sleep system. The sleep system's there waiting to work. So why would you want to hit her further? There's a few drugs, maybe melatonin, maybe Rosarum, that are approved for sleep. Melatonin's off over-the-counter supplement, which are probably primarily working on the circadian system reminder for sleep rather than sedation per se, unless you take really big doses. But the dual Orexin antagonists were the first drugs to shut off the daytime arousal. So Max asks, have there been newer studies on the DORA agents in the past couple of years? Any additional research looking at dosage or short-term use versus long-term use? So one of the strange things, and there's a New Yorker article maybe 5 years ago that went into this in detail, and it's fascinating, is the first, so Belsomra for years, probably at least 5 years, was the only DORA agent authorized by the FDA. In their so Belsomra is approved for 5, 10, 15, and 20 milligrams, and the company's own data suggested that I may have the numbers slightly off, but 40 and 60 were safe and effective, more effective, at least 40 was, maybe not as high as 60. But what the FDA said, and this to me is remarkably unscientific, they said, all the other drugs we've approved for sleep looked safe and good until we got them on the market, and then they had lots of problems after we got them on the market. So because this is a sleep drug, even though it's working in a completely different mechanism of action, we're only going to approve lower doses than you have demonstrated are effective and are safe. And the company decided they'd rather have some approval than fight for what they had demonstrated was effective. So that's one little bit on dosage. So probably, and there have not been extensive studies since on looking at higher doses, but probably they tend to be safe and effective. So one difficulty in looking at side effects is most side effects with these drugs are uncommon. And the population that they're being used in is people who have insomnia. And insomnia itself can result in all sorts of strange, both nighttime and daytime behaviors, memory problems, other issues. It's not clear that there are side effects that are more prominent for the DORA agents than with the placebo drug in a group of people with insomnia to begin with. There's like 2 or 3 studies and with tiny, tiny sample sizes. So one of the concerns, and I'll be putting together a video on this in the next day or two. So maybe to steal the thunder of that one, there's been lots of concern. The benzodiazepines seem to be associated with higher risks of developing anxiety, or not anxiety, but dementia. Whether this is a confounding factor that you're treating anxiety, which is itself a risk factor, or whether these drugs are directly having some role is unclear. But one recent study by University of Rochester neuroscientist, she also has an appointment at University of Copenhagen, Maken Nedergaard, who's the team, her lab, discovered the glymphatic system, the cleansing the garbage from the brain system. Anyway, I'm going into my next video. So her group recently, just in the last few weeks, released a study showing that Ambien can interfere with the glymphatic pumping system, making it that there is a plausible mechanism by which Ambien and maybe presumably other non-Z drugs and other full-blown benzodiazepines may be interfering with the cleaning system of the brain and allowing beta amyloid and taut fibrillary protein tangles to build up. Again, one study doesn't prove it, but it's alarming. So what's interesting on the other side of the equation, there's both one study in mice and 1 or 2 studies in humans, again, very small sample size, suggesting that Belsomra, Orexin, may actually improve the brain's ability to clear out toxic garbage, specifically beta amyloid plaques, I believe, or whether this is just because it's enhancing deeper stages of non-REM sleep or whether it's a more direct additional benefit is unclear. So those are the more recent studies on DORA drugs that I'm aware of. So Sniper Channel says, I have psychological pain in my heart and it's exhausting. I feel for you. This is why I'm in this line of work and trying to help as many people find solutions to their pain. I'll be a little critical, and I think the pain is really in your brain, not in your heart. Not that the brain can't therefore then go back and influence the heart, but there's increasing evidence that both psychological pain and physical pain, if you hit your finger with a hammer or stub your toe or some get burned, that much of the brain circuitry involved in pain is shared in common, but there are also separate additional parts of the brain that are activated with psychological pain. But there is a lot of overlap. So it's probably not just fair to consider a metaphor when we talk about psychological pain. It's pain is pain. Have I come across psychological pain working with others, or whether it's a question about my personal life or asking research about it? I'm not, or maybe I'm completely misreading it. This won't help me pronounce things better, but at least I can see all the letters. So Mohsin Ali asks, in my clinical experience, which supplements or non-mainstream medicine work best for ADHD in order of effectiveness? Thank you. So This is my own personal philosophy, is I tend to be reluctant to prescribe or recommend things unless there's a substantial body of data that shows that it can be helpful. Um, so I'd say the two that stand out, and I do have some talks on some of these, maybe three. I'd say fish oil, magnesium, and N-acetylcysteine may be the ones that stand out. One, this does not mean that there may not be other substances, saffron, other things out there that may be substantially better, more helpful, or help a wider variety of people. But until we have the data, I'm reluctant to recommend things. Two is I'll start with the fish oil. The first several studies that were done on fish oil did not show any benefit for kids with ADHD relative to the placebo controls. And then several studies did find some measurable benefit, and the field sort of jumped on the more recent studies and said, oh, we proved that they work, without incorporating, why were the previous ones not showing an effect? And it could be different formulations, different dosages. But I'd say there's often a failure to fully incorporate the whole body of research and just jump at what the most recent studies show, either positive or negative. So I do have a talk on fish oil. I do have a talk on N-acetylcysteine and magnesium. And I'd say magnesium is probably the one, and most of the people I've used it have taken it in the evening for sleep, that people have reported sort of robust and rather immediate beneficial effects for their ADHD symptoms. So again, I do have separate talks on all of those on this channel. So Max asks, is there any validity to the claims that a higher protein diet may help the effects of stimulants? Since stimulation consumes more calories, you may need more available. So I have not investigated in depth. I don't know of any studies comparing a high protein diet to a low protein diet. Part of it is that proteins, when they're broken down into amino acids, some of those are the precursors of dopamine, norepinephrine, and serotonin. So the thought might be that you are boosting the synthesis of vital neurotransmitters. Again, unless insufficiency of those amino acids is the critical step, and I do have one of the more arcane talks that nobody wants to listen to on this talk. Throwing more basic ingredients into the mix does not necessarily achieve more output at the end of the system unless they're affecting the critical step. So that's sort of the silly analogy. If you have an assembly line and you're not making enough neon volts coming off the line, and you think, oh, well, I've just gotten an extra big shipment of left side passenger or left side front seat doors, I'm going to rush those to the assembly line and I'll be able to make more cars. But if your deficit of left-handed doors was not what was slowing down the assembly line, rushing more of the raw ingredient in, or the basic building block, is not going to have greater throughput. So other ways, high protein diet can also, if it's really high, slightly acidify urine. And I do have a talk about acidification of urine and blood and how that may help clearance, availability of drugs. I'd say for most people that doesn't seem to be a huge impact, but some do seem to be more sensitive. So with stimulation, consuming more calories, you may need more available. So, protein is a source of calories. Carbohydrates are a source of calories, but if you really want calories in terms of milligrams of food you're eating, fats are a little more than twice as caloric rich. So if it's providing simply energy, then you would think a high fat diet would be where you'd want to go. So I'm not seeing any new questions coming in right now, but there are a number of you listening, so maybe someone will chip in. There. Mr. AKA said Depakote is sometimes prescribed off-label for anxiety in some places in Europe. What are your thoughts on that and the idea of using HDAC inhibitors with CBT to enhance fear extinction? So Depakote is originally an anti-seizure medication, and in the US, it's approved for treating bipolar disorder. It's also recommended off-label by some professional organizations for explosive temper or explosive, there's another word, something explosive, something disorder, incident event disorder. So it may help with volatility of mood in settings other than just pure bipolar disorder, and then potentially in ADHD, where emotional dysregulation is a common, not ubiquitous, but common situation. I'm not familiar with research showing whether it's particularly potent for anxiety or not. I mean, anxiety, as with depression studies, there are large placebo factors. So again, I just don't know. I'm not familiar with the precise studies. I don't know if there's studies looking at it with CBT to enhance fear extinction. So Sniper Channel is repeating their question, and I'm still not clear what the answer is. I mean, they're saying I have psychological pain in my heart, and it's exhausting. And yes, pain wears us down. Pain is fatiguing. Pain is taxing on our systems. Sniper ER is taking duloxetine, and hopefully it's helping somewhat. If it's helping somewhat, it's possible that more may help more. So many doctors seem reluctant to dose Cymbalta duloxetine above 60 milligrams in the US anyway. And yet when it was approved in the 60 to 120 milligram range. And I usually am fairly conservative in doses, but I'm also willing to go high if someone's not having problematic side effects and obtaining benefits. So I have seen substantial numbers of people do better on 90 or 120 than on 60. So Max is asking, how does one differentiate between state of ADHD type, apathy, lack of interest, understimulation versus anhedonia? So anhedonia, which is defined as not being able to obtain joy from anything, is a central symptom of depression. Again, the way depression is defined, even though most people may have anhedonia, you certainly can have depression without anhedonia, but it's closely linked with depression. So differentiating apathy, boredom, lack of interest, understimulation would be how to differentiate between ADHD, apathy, and anhedonia of depression would be putting the person in stimulating, interesting environments. So if someone with ADHD, if you find what brings them joy, if you find, so we often say people with ADHD are interest-driven, not importance-driven. If you can find what's interesting to them. Where that comes tricky, though, is even people who are profoundly depressed may have a few minutes of joy while if you find something they particularly like, they may get very temporary relief, but prevailingly in all areas of their life, they'll describe things as flat, meaningless, dull, uninteresting. And particularly in their recollections, and this is my clinical experience, I don't know if this has been rigorously studied, given that the depressive mindset is so pervasively negative, That's objectively, measurably true. They often will downplay if you say, well, you were just smiling at that joke I told you in the session. They'll say, oh, well, it really wasn't funny. I really wasn't laughing. Or, even if they engaged in, watched a 20-minute video they really liked and were smiling and laughing, they will downplay it or minimize it afterwards. Whereas the individual with ADHD is usually able to acknowledge that, yes, that was good, that was fun, that was valid, but I'm not in that place now. And this is the other confounding factor, is that depression and ADHD are associated more commonly than you would expect from the rate of either one alone. Some of that is almost certainly common genetic factors, but some of it is also almost certainly that ADHD drives depression, that if you, by society standards, continue to not meet society's expectations or measurements, then you are more likely to wind up feeling defeated and inferior. It's a little ultra paradoxical. Recently, I've been taking melatonin every night, 3 to 4 milligrams. Is this a bad idea? So, a couple things and I do have a talk on melatonin. So, one thing with melatonin, and this was true in the 90s when I was starting work, and it's been true in recent surveys by organizations like Consumer Reports, which assays products on the market. Of all the supplements I'm familiar with, all the common things, melatonin is very consistently the least consistent in terms of the label corresponding to the dose you're actually getting. And it's not just giving you less than they say, it's sometimes giving you more. So there's something about either the stability of melatonin or its processing that makes it hard to be consistent with. So I would say if you find a brand that works for you, probably stick with that brand, because their 5 milligrams may be substantially different than brand X's 5 milligrams. The second thing is that so your own body, your own pineal gland should be making melatonin happily every evening. So there's a circadian rhythm to it, but it's also influenced or suppressed if you have bright light in the evening. And to some extent, taking it from an external source, there are feedback loops along with the circadian system may just result in your own body producing less of it. Most of the experts suggest dosages of 1 or 2 are safer in the long run and less likely to disrupt your own body's ability to produce it than higher doses. But again, given that it's hard to know what you may be getting in 3 to 4, I'd say if you can slowly decrease it to closer to 1 to 2, that may be safer. So Sniper asks, is the intense desire to cry, is it related to serotonin or norepinephrine? I mean, my guess is that both are involved. I mean, one thing that's interesting is one of the most prominent signs of serotonin withdrawal is extremely ready. So people who've been on an SSRI for months or years and then stop it abruptly, in addition to gastrointestinal and some neurological withdrawal effects, fairly often cry at the drop of the hat. So that would suggest that serotonin is intimately tied into it, the ease of crying. So Ultra Paradoxical asks, are there concerns about daily melatonin use? Again, you're at some level, you're getting daily melatonin use because your body is producing it every night and delivering it every night. So the question is more, is there a dosage range where daily use is alarming or problematic? There were some concerns 10, 15 years ago whether melatonin could increase rates of cancer, have some effects on suppressing tumor or genesis, suppressing mechanisms that inhibit tumor growth. And to my knowledge, the studies that were done didn't find any clear association between taking doses of melatonin and cancer, but I don't have those at the top of my head, so that's all I can say with any certainty. Piotr Volanin asks, how are you supposed to feel when you are relaxed? I'm thinking the inability to relax among people with ADHD. So that's a good question. In psychology and therapy, we often say you're not supposed to use the word suppose, because that presumes there's an expectation and a right way of doing things, and there's a wide variety. But the point I get is if your brain is always jumping around, if your body's always bouncing around, if you've never felt a state of calm, how can you relate to it? How can you understand it? How can you know it when it's there? Or how can you know that you're not having it, given that we never know what someone else is feeling related, how it maps onto what we're feeling? One is that many people, and this is only part of the answer, is many people with ADHD can hyperfocus, and hyperfocus usually involves a state of intense enjoyment and engagement, but also some relief from anxiety or worry. So at least one component of relaxation is actually there is a component of hyperfocus. If you're still, so again, you feel in the moment, you feel in sync with things around you, you feel that what you're doing may be challenging or difficult, but that you will succeed in it. And that's a little different than just feeling anxious and that driving you to work harder, study harder, learn harder. So I don't have anything more to say. So Sniper Channel asks, do I go above 60 milligrams of duloxetine for people with ADHD? So again, I'm not making a specific recommendation here, but yes, I have very clearly, definitively, and going back and forth with dosing, convinced, at least to my satisfaction and the individuals taking it, there are some individuals who do get substantially more benefit for ADHD symptoms from duloxetine at 90 or 120 than they do for 60. I can also unequivocally say that's true for depressive effects and anxiety effects and for pain relief effects. So for all of those symptoms, there are many people who get full, robust benefits at 60 milligrams. But if you're not and your side effects are manageable or tolerable, then for many individuals, and again, I'm not making specific recommendations, it's probably worth exploring going higher up to 120. I don't routinely go above 120. I have had some people who came to me on doses above 120 who seem to obtain benefit and not have any problematic side effects. Mr. AKA, do you know much about oxytocin and oxytocin receptors in the brain? Is there any opportunity there to develop drugs to treat any particular type of condition? So there are oxytocin drugs in development, particularly as nasal sprays, because oxytocin is a polypeptide that in a pill form, if you take it, you'd be mostly digesting it to its basic amino acids, but delivering the molecule in by a spray. So it's most of the research that I'm familiar with has been looking at borderline personality disorder and I'd say mood and anxiety, depression, anxiety somewhat. So oxytocin seems to be an important neurotransmitter involved. So there are receptors in the brain. I don't know off the top of my head or even in the middle of my head or the medial or lateral parts of my head where receptors are particularly concentrated. So it's a drug that seems to foster association, connection. There's interesting studies on comparing social types of voles versus solitary voles. Voles are little mice-like rodents, showing, again, importance of oxytocin. So one thing with oxytocin is it doesn't just create positive feelings of connection, which was sort of some people were pushing it as the love neurotransmitter a few years ago, or sort of like your body's form of ecstasy. One is it can heighten awareness of interpersonal reactions in a positive way, but some of the studies, particularly done with borderline personality individuals, suggest it could also heighten the negative impact of intersocial communications or rejections. So I don't know what stage whether it's close to being brought to market or whether it's seriously being done in phase 2 or 3 studies. So Piotr asks again, how do stimulants compare with alpha-2 agonists compare when it comes to helping people with ADHD calm down their mind? So I don't think there's been a head-to-head comparison between alpha-2 agonists like guanfacine and clonidine, which are FDA approved for ADHD. Well, guanfacine is versus stimulants. So clearly there are many individuals with ADHD whose minds are calmed down by either type of agent. There are, including many hyperactive people, where you would think, oh my God, giving them a stimulant is going to make them bounce around more physically and mentally. And yet being able to organize your thoughts, control your thoughts, prioritize your thoughts, respond to the appropriate stimuli without getting distracted by irrelevant stimuli can be an incredibly calming experience. So stimulants can calm down many people with ADHD, and guanfacine alpha-2 agonists can also do that. There are many people, or at least a sizable minority of people with ADHD who don't tolerate stimulants very well. And as we've talked about here a little bit, for many of those individuals, starting them on guanfacine, getting them stabilized, and then if they need to do more to address ADHD symptoms, then many of them find that stimulants are less revving up, less activating, while helping with ADHD symptoms, but not contributing to anxiety. So lamotrigine is another, or initially in the US anyway, an anti-seizure medication approved as a mood stabilizer. It has some action on NMDA receptors, but it also has additional effects on the brain. So I talked about it, I think, very briefly in the glutamate receptor video. And to my knowledge, I'm trying to remember this subgroup of people. It might have been people with seizures, tic disorders, and ADHD. To my knowledge, it hasn't been looked at in a clean sample of people who only have ADHD. So lamotrigine, compared to other mood stabilizers used for bipolar disorder, is particularly benign in terms of most people don't have side effects. So most of our other mood stabilizers, whether they're the atypical antipsychotics, whether they're lithium, Depakote, which is valproic acid, carbamazepine, all of those tend to be, this is an oversimplification, tend to be sedating, tend to cause weight gain. Lamictal, lamotrigine, extremely unlikely to do either of those. Gastrointestinal side effects are uncommon. But lamotrigine, unfortunately, has the commonest set of side effects tend to be rashes. 10 to 15% of people have rashes. Almost all of those are completely benign, will resolve, aren't harmful. But lamotrigine, particularly if you start too high or taper up too quickly, is associated with a Stevens-Johnson type rash, which essentially forms type 3 blister burns over your body, and can be fatal if not caught early enough and stopped early enough. And in the early stages of a rash, even expert dermatologists usually can't differentiate from a potentially benign rash and a harmful rash. So usually if someone's developing a rash on lamotrigine, the recommendation is stop. Whether it's worth retrying in the future is a different point. But again, the research with it for ADHD, even with comorbidities, is really limited. And I'm not aware of any studies looking at it in just people with ADHD. So thanks, Max, for keeping things going. Max says, I've mentioned that about a third of kids outgrow their ADHD. Is that for kids who took treatment? And is it lower without treatment? Is it possible those kids were just misdiagnosed? So one is, usually when I talk statistics, I use big round numbers because studies depend on what population you actually looked at, what measures you used. So when the people say 14.7% of kids outgrow their ADHD and 36, to me, it's a meaningless precision. And it depends a lot on how you define ADHD continuing and how well you look for symptoms. So my ballpark figures are 30 kids with ADHD don't get any better. The severity is about the same. About a third seem to outgrow some of it, and outgrowing may be that they've just developed techniques, tools, or ways to find situations that are a better match for them. And about a third do seem to primarily, and the number is shrinking, so it's probably less than a third really fully outgrow it. So some of those are people who are functioning better. But again, the statistics are pretty broad ballpark numbers. I'd say that from what I've seen in terms of follow-up sequential studies and sort of rigorously evaluating, I do think there are kids who have rigorously well-defined ADHD who do outgrow it. I do think there is overdiagnosis in kids with ADHD as there is within adults. I do think it's still wildly underdiagnosed in adults as well as overdiagnosed. So the big question, so what we know is that the brains of kids with ADHD who take stimulants during childhood years look more closely like non-ADHD brains than like ADHD brains compared to the kids who did not get treatment with stimulants. But whether that reflects that overly simplistically, we've really cured some kids through treatment, or whether some kids were just going to outgrow it anyway. I don't think we have clear-cut, robust answers to that, and particularly what percentage of people would fit into each category. So I'd say really good questions, really important questions, and a deficit of good, rigorously done research, which this would be particularly expensive research because multiple time points cost money, multiple time points over multiple years costs lots of people hours. And separate from just the sort of cost investment for a researcher who's trying to get a faculty position or maintain their life in academia, you'd much rather have 3 studies you can churn out and publish in a year or 2 than one big important study that takes you 15 years or 30 years to produce. So there are sort of institutional barriers to doing some of the good work that needs to be done. Margaret Sibley is one of the people most strongly associated with investigating questions like this, and she may have studies designed that are addressing this. So some of her work was ones that showed that if we use a strict formal criteria, there's lots of people with ADHD who go back and forth between full-blown ADHD and subsyndromal. So in the 80s, 90s, maybe in the first decade of this, it was sort of you have it or you don't, and you get rid of it or you don't. And now the conception is that it's much more fluid in the propensity to continue to display some ADHD symptoms. One is dependent on the environment you're interacting with, and two can fluctuate over time. So Max says, I sometimes hear people make the puzzling claim that the effects of SSRIs for depression is around 70% placebo. Is there any research to support that? So I'll start, by saying, and I've talked about this one before, I'm happy to talk about it again. I think the biggest problem plaguing all mental health psychiatric research is we still lack good measures for depression severity or even its presence or any other condition. And I'm not trying to belittle. There are many very bright people who have spent their careers developing measurement tools. And all of them, all the tools, you're still going to have overlap or leakage with other. So the ADHD measurement tools, if you're depressed, if you're anxious, you're going to score differently on some of the measures, some of the questions. So part of it, I think if we had better markers, it would be much more clear that people do respond to SSRIs. So one camp actually argues SSRIs don't even do anything. That's the extremist camp. But the milder version is that 70% of the effect is placebo. And that claim comes from really high rates of responding to placebos, in some studies in the 30, 50% range. So if your success rate is 60%, but 50% of people respond, 40%, let's just keep it easy. 40% of people responded to placebo, 60% responded to the drug. You would say, one way of looking at it is 60% of people responded to the drug. The other way is to subtract it out. So you'd say, only 20% of that benefit is people responding. But the other way of mixing with the math is saying, of those 60 people, given that 40 would have responded to placebo anyway, 2/3 of that response is a placebo response. It's sort of eliminating or looking that you may have both a placebo effect and a real drug effect going on at the same time in the same individual. So I don't know if I've answered that well, but that's, part of it is how so some of it is that is not even questioning which numbers you're using, but how you're choosing to interpret or claim them. And the other thing that, again, underlies our lousy measures, if you look at sort of the time course, so placebo responses for depression tend to be people responding in the first week or two and then tailing off over time. Treatment responses to antidepressants, at least of that category, tend to be minimal in the first week or mild, and then by weeks 2, 3, 4, gradually becoming more robust and distinguishing from placebo group. So it depends what time point you're looking at. And there's some claim that there's other qualitative data which would help us distinguish who's getting really a placebo response from a genuine antidepressant response. But again, all plagued by sample collection measurement difficulties. I have about 5 minutes before I do need to go. So there's a lot of research about the use of cranial red light, infrared light therapy for a number of mental health disorders. There are a number of helmet devices in the market. Could it help in ADHD? So parts of the brain do seem to respond to neurons in the brain do seem to respond to light, particularly in the infrared which region. I guess I I'm not familiar with any studies that have been done on ADHD, so I just can't comment. That may be a good topic to look into further. Um, and again, this is one area where there's certainly potential for placebo effects. And this is in clearly making a distinction. This is different from phototherapy for depression, particularly seasonal depression, where it's light in the visual part of the spectrum, particularly the blue end of the spectrum, that robustly helps alleviate seasonal depression and may help with a number of non-seasonal depressions, and particularly morning delivery of light that is bright enough and including the blue spectrum. So this is a different setup and a different delivery and presumably dramatically different mechanism of action. So I will look to see if there is any ADHD research. So I do have some patients to talk to in a minute or two. So thanks for being here today. Thanks for asking good questions. If there's other requests or interest in certain topics for future videos, let me know. And we're also thinking of ways to organize the site. YouTube doesn't allow you or doesn't provide a lot of tools for structuring how videos are displayed, grouping them or otherwise. But as the site becomes more unwieldy, or the channel, we're looking into ways of making it more user-friendly or finding what you need or want. So thanks for being here today. Stay healthy, stay happy, and I will be back next week.